Okay, let's jump right into this explainer. We're unpacking the complex world of low back pain using clear, structured data pulled directly from top medical guidelines. I mean, if you've ever felt that sudden twinge picking up a heavy box or that nagging, dull ache after sitting at your desk all day, you know exactly how disruptive back pain is. Today, we're going to break down the science of the spine, separate the myths from the facts, and lay out a real, evidence-based blueprint for healing.
What's wild is that nearly 80% of people will experience this at some point. 80%. That's 8 out of 10 of us. If your back feels fine right now, chances are someone close to you is dealing with this. It's literally one of the most common musculoskeletal issues on the planet. So the stuff we're covering today is incredibly relevant to almost everyone watching. You are definitely not alone in this.
Here's our roadmap for today. 1. The anatomy of back pain. 2. Causes, classifications, and risks. 3. Red flags and diagnosis. 4. Movement as medicine. And 5. Clinical cases and guidelines.
Section 1. The anatomy of back pain. Zooming in on the spine.
The crucial point to grasp right off the bat is a core concept from modern pain neuroscience. Low back pain is a symptom. It is not a disease. And honestly, it's rarely a sign that your back is permanently damaged. When you feel that ache, it could be coming from muscles, ligaments, facet joints, nerves, or the vertebrae themselves. Think of it as a signal your body is sending, not a life sentence. Take a look at these key lumbar structures. They brilliantly illustrate our normal biomechanics, working together to distribute loads, absorb shock, and stabilize your core. You've got the lumbar vertebrae, L1 through L5. Between those are the intervertebral discs, which have a tough outer ring and a jelly-like center, acting as literal shock absorbers. Then there's the cauda equina, those nerve roots below L1 and L2, all wrapped up by powerful stabilizing muscles like the multifidus and erector spinae. It's a total masterpiece of biological engineering. Section 2. Causes, classifications, and risks, categorizing the pain. Now let's contrast the super common mechanical low back pain with sciatica. Mechanical pain is highly localized. It's that stiffness or muscle spasm right there in your lower back. Sciatica or radicular pain is an entirely different beast. That is caused by nerve root irritation, and it shoots this tingling, numbing pain all the way down your leg, usually below the knee. Treating the right one means knowing exactly what we're looking at. Time is another major factor here. It's actually pretty reassuring to see that most acute episodes, meaning those lasting less than 6 weeks, improve rapidly. Subacute pain hangs around a bit longer, between 6 and 12 weeks, but once it crosses that 12-week mark, we call it chronic, and that usually requires a much more comprehensive, multidisciplinary strategy to manage. So what actually puts us at risk? It's not just heavy, repetitive lifting or a sedentary lifestyle, though prolonged sitting and poor ergonomics are huge culprits. What's absolutely fascinating is the psychological side. Fear avoidance, literally being scared to move because you think you'll cause more damage, along with high stress, are massive risk factors for chronic pain. Toss in obesity and smoking, and you've got a perfect storm. Section 3. Red flags and diagnosis. When to worry and how to test. Okay, there are a few stark medical emergencies, or red flags, where you need urgent evaluation. We're talking about rare but critical things like cauda equina syndrome, where you might experience saddle anesthesia or lose bowel and bladder function. Other red flags include progressive neurological weakness, severe trauma, or if you have a fever paired with back pain, which might point to an infection. A history of cancer with new back pain is another big one. It's all about making sure we don't miss any severe underlying pathologies. But let's assume there are no red flags. What does the physical examination journey look like? If you go to a clinic, expect a hands-on investigation. They'll observe your posture, analyze your gait like you're walking a runway, and check your lumbar range of motion by having you bend forward and backward. They'll do a neurological exam testing myotomes and reflexes, and run special maneuvers like the straight leg raise or slump test just to see if your sciatic nerve is under tension. Section 4. Movement as medicine, the blueprint for healing. We are witnessing a massive shift in medicine right now. The outdated practice used to be prolonged bed rest, immediate imaging, and relying on passive modalities. But we now know that prolonged bed rest actually delays your healing. The evidence-based practice, staying active, using targeted exercise, and getting early education, that is your absolute best and fastest path to recovery. Enter the modern physiotherapy toolkit. These techniques are designed to restore function and build back your confidence. You've got patient education based on pain neuroscience,
the McKenzie method, which focuses on movements that centralize that radiating pain, core stabilization exercises like abdominal bracing, and the bird dog, plus motor control and lumbar mobility work. And while manual therapy feels amazing, the data clearly shows it's most effective when combined with exercise. Section 5. Clinical cases and guidelines, real-world applications. Remember, treatment is highly individualized. Look at these scenarios. A sedentary office worker with acute non-specific pain, they need an ergonomic setup and a simple walking program. But an active athlete with recurrent mechanical pain, they need advanced core stabilization and mobility work. And for an older adult with lumbar spinal stenosis, where standing straight up hurts, the priority shifts to flexion exercises and functional rehab. It's definitely not one size fits all.
Zooming out to the global authorities like the WHO, NICE, the APTA, and the ACP, there's a remarkably unified consensus. Exercise is the first-line treatment. Avoid bed rest. Manual therapy works best with exercise, and routine imaging is not required for uncomplicated cases. The global takeaway is that education and self-management are absolutely essential.
Now, let's do a rapid-fire review of a couple of burning questions to really cement this. First up, is bed rest recommended?
The resounding answer is no, absolutely not. Avoiding prolonged bed rest and remaining active actually improves your recovery time. Resting for a day after a bad spasm is one thing, but your tissues literally need movement to heal and restore blood flow.
Here's another super common question that drives a ton of anxiety. When is an MRI actually necessary? Imaging is only preferred when serious pathology, those red flags we talked about, or persistent radiculopathy is suspected. Routine imaging often shows totally normal age-related changes that just scare patients for no reason. We don't need to see every little quirk of your spine unless those specific warning signs are there. I really want you to take this empowering quote with you. Low back pain is one of the most common health problems worldwide, but in most cases, it can be successfully managed without surgery. With early education, regular movement, and healthy habits, conservative active management is the absolute gold standard for the vast majority of us. So, knowing that movement is the ultimate medicine for the 80% of us who will face this, what steps will you take today to support your spine? Whether it's fixing your workstation, taking a brisk walk, or just avoiding the couch next time your back aches, the power to heal is largely in your hands. Thanks for joining me on this explainer, and keep moving.